Welcome to our latest edition of our Brain Talks, a podcast series under the umbrella of the Brain Innovation Days. In today's Brain Talk, we welcome back a speaker from our April event, which focused on the impact of COVID-19 on the brain community. Though the pandemic has seen positive effects on the innovation side, it cannot be ignored that it also had heavy impact on the community, both mental and neurological. There is a wide consensus that COVID-19 pandemic not only affected physical health, but also mental health and mental well-being. Psychiatric clinics globally have been forced to modify their practice in order to guarantee care and support to people with mental health problems, but also for those who are not mentally ill but are suffering from the psychological consequences of the pandemic. Today, we are pleased to welcome Professor Peter Falkay, the President of the European Psychiatric Association, to help us better understand and dig deeper into the impact of COVID-19 on mental health. I will be your moderator, Frédéric Destrebec, the Executive Director of the European Brain Council. So let's get started. Thank you for joining us today, Peter. As mentioned, you are the President of EPA, the European Psychiatric Association. Before we go into the content of our discussion, maybe you could tell us more about EPA and about your personal background.
Yes. First of all, thank you very much, Fred, for inviting EPA and me for this occasion. Well, EPA, European Psychiatric Association, is a society which actually consists of more than 40 European countries. And if you look at the amount of psychiatrists, we have 80 and more thousand psychiatrists actually gathering under the umbrella of EPA. And the basic idea or message of the EPA is that we want to actually unify European psychiatry and help to improve the care for people with mental illness. And I think there are a lot of things which have to be done. I always say just one number. 1 out of 4 people in Europe have a mental illness. About 1 out of 10 have a mental illness and need help and support. And you can just think about the numbers we have there.
Peter, during the event, the last Brain Innovation Days, your intervention touched about the impact of COVID-19 and how it impacted the mental health community. So, given these numbers, can you maybe tell us a little bit more on maybe how it is aggravating certain issues there?
Well, you see, I think you should take into account that mental illnesses, to a large extent, are stress associated. So the more stress you have, the more likely it will be that people who are at risk to developing a mental illness will actually develop it. And COVID is a maximum stress to humans. I mean, first of all, there is this being anxious, do I get the virus? Don't I get the virus? And the second thing is, in order to prevent the outbreak, we had to pay with social isolation. And both things people don't like, being pressed, not being able to move, and then being isolated, not meeting friends, not being able to interact is stress for people. And as a matter of fact, there were 3 groups which were affected by COVID. First of all, the healthy population. We now know that about 10% of the people vulnerable for mental illness, they do develop sleeping problems, anxiety, restlessness, and, at a later stage, really anxiety disorder and depression. So as a matter of fact, and that is clearly documented, there have been more people developing these illnesses. Second group, actually, and this is quite frightening, that people with mental illness, they have an increased risk not only of developing mental illness due to the stress, but they have a worse prognosis if they get COVID. And the reason for that is that most of these people have comorbid somatic problems like lung disease, cardiovascular disease, which makes them more vulnerable. So indeed, I think there we have a group of people who have a higher risk of getting worse concerning their mental illness and their somatic illness. And the third group, just to mention, are the professionals. I think we need to account that, there are a lot of people who work in the hospital or in the community, And that was a mega stress for them, to be on alert, to work, in the last 1.5 years. So I think COVID was a maximum pressure as on the human community and European community as well.
But on this note, and maybe on these different parts of the population, as you just mentioned, how collectively you could see that there was an adaptation in order to be able to cope, because obviously we already had speakers coming in to talk to us about the increased use of telemedicine in order to let's say mitigate the disruption that actually we were all faced with. Would you see that there was a spike in telepsychiatry, and what sort of new trends did you notice in that respect in your clinical practice?
Well, I think you note a positive effect because, I mean, telepsychiatry, or let's say using telemedicine in psychiatry, was a bit on the slowish side, I have to say, to be critical on our own sort of people. And I think that COVID, in the beginning, nothing really happened. We shut down everything. But I think that once the first wave was, coming in, then telemedicine sort of rose. So you can quite nicely see, for instance, in our hospital and in other hospitals too, the possibilities to interact, for instance, with psychologists, with psychiatrists, virtually increased dramatically. So before that, there was only the possibility you could actually have an appointment and meet someone personally. And now you had the possibility actually to link in, get information about COVID and infections, then make a rating of yourself, how do you feel, and then get an offer, of a counseling just one time or several times, or then have psychotherapy. So what happened there, that I think we have actually got use of the telemedical possibilities, and I think that is very helpful. The problem we have now, we shouldn't forget these things, and we shouldn't fall back behind what we have learned. So I'm always giving one example. So it's not only in outpatients to follow up patients, for instance, at home, or for instance, at a GP's place. But the other thing is often we go and see patients in other disciplines like surgery, internal medicine. And now we started to actually use iPads and so forth. So the patient could actually log in and you did the interview. And now what you can see is that, if one of those machines is broken or things, then people say, oh, psychiatrists should come and see the patient personally, which is fine. But still, I think we should continue to use this progress we made in telemedicine and even, be able, because we can actually then approach people we couldn't approach before, and we can offer people with mental illness more closely, counseling, other things in other situations people couldn't because it's a too long way to travel and things like that. So yes, we caught up. Yes, we need to stick to it.
But did you feel equipped when you had to take up this kind of new tools and new technologies? And you say no, actually, it was great in a sense to be forced into using those because you realized it's a clear added value. So, but what sort of challenges did you see in terms of how to accept that in the daily use, and also maybe with your colleagues? Maybe not in your name personally, but I don't know if some colleagues were probably a bit more reluctant, or what sort of challenges could you identify in taking this up?
Well, first of all, you said, were we equipped? And the clear answer is no. It started with the effect that we had computers with no camera. So you wanted to do a Zoom and you couldn't see a thing. You could only hear the voice. So then we wanted to buy little cameras to put it on the top of the laptop or the computer. The problem was you couldn't buy these cameras because the market was empty. Mm-hmm. Second thing is, you see, having enough possibility to actually use Zoom, for instance, on a ward and so forth. We had to realize that we had, wards and so forth, but there was not enough wireless LAN. So I think that, we needed to catch up. And my impression was it was good that this, that this happened, within a short period of time. Because before that, there was, beside the question of money, there was always, the question is, of the personal rights of the people, to defend that, to protect personal rights and things. But with COVID, a lot of these things have been solved. Not that they just, torn away, but solved. And I think that was a big leap forward. Now we can use these things. These are protected lines. Now we have, psychotherapy. We use Red Connect. We know that these are protected lines so that the information we actually transfer, so when we actually work with the patient, these informations are not lost somewhere in the space and, then put up to anywhere. I think these are important things. And that was solved within a few months. So I think we started very low. We have now a good niveau, and we need to continue that.
And would you say that these techniques are fully embedded into referral systems, or that they are true, let's say, add-on in your process of diagnosis or management or monitoring of patients, or there is still work to be done in order to fully embed that into, I would say, the full chain of the care and the service?
Again, I would say a clear no.
Okay.
Yes, because you see, the thing is, beside having the equipment, having the cameras and things like that, and this is a very important question you put up, is you need to change the way we treat people. And all of us, I think if we do a good job, I think that, continuing doing good outpatient and community-based psychiatry after COVID will be a different one. But people will always say, oh, this is difficult, I don't see patients. And I say, why? We need to think about it, Why is it not possible that, I do a first round with a patient and then I do a follow-up virtually 5 to 10 times? And once you get used to that, it's fine to people. I know people who actually leave the hospital, they sit outside in the sun and they do the psychotherapy, and then you say, this is new. In the past, you would have sat into your room and it is dark and small. Now you sit outside, have a coffee, and do joyfully the psychotherapy. So, short answer, I think there is still a lot of work in order to implement these virtual tools, these telemedical tools into everyday praxis. And I think it will take some years to continue and actually motivate people to continue that and not fall back to what we had before COVID.
Yeah, and I remember a discussion we had with one of your colleagues let's say belonging to the neurological space, but who was saying that actually teleconsultations and the use of telemedicine and other IT tools helped him to become really closer to his patients, because obviously there was also a time efficiency by the fact that we don't need to change room and stuff like that, so we can have, let's say, a quicker rotation from a patient to another. But then we see patients in their household, so in their intimacy, which was never the case, because they were rather coming to the hospitals or to the praxis. But at the same time, even if there is, let's say, this increased level of closeness with the patients, the fact that we see them in the let's say more privately than ever before, there is still this physical distance that is now due to the virtualization, and the combination now between embedding those let's say tele or remote consultations with a real doctor-patient interaction was probably the challenge, according to him. What would you say? What would you say about that?
Absolutely. I think, you see, we need to think about, as we said, new ways for diagnosis and treatment. I think that it no longer is necessary that possibly a patient needs 2 to 3 months until getting a sort of appointment for a full workup. On the other hand, there might well be the situation that you need to have let's say, a workup. But the question then is, why not leaving the patient who is 100 kilometers away from you, and then there's someone going and, doing the examination while you sit and say, oh, could you do this and that? And you've come to the same conclusion. So I think these are new ways. And the other thing is, you see, what I find very positive, to put together people in a round on one patient. I think often mistakes happen because there is one expert who has a certain idea and a certain angle and looking at that, which, if it's easy, this is no problem. But if it's getting difficult, and if this patient has several disorders, so for instance, a combination of neurological and psychiatric disorders, you need at least 2 experts, right? And I think that virtual tools are a wonderful possibility to bind people together, and then, even bind the patient in there, bind the relative in there. Never ever in my life did I have so many interactions with relatives, because it's easy now. You send a Zoom, most people will have a laptop or a computer, they link in, and it gives you like half an hour to discuss what happened with my son, with my daughter, or with my mother, or with my spouse. So, that is what we need. I think in a way we need to rewrite our textbooks about, a passage, or add in a passage about, virtual psychiatry. So, what are certain rules? So what is the minimum we need in real interaction to be on the safe side? What can we do virtually? When do we do a follow-up in order to have good quality? I think these things need to be studied and put down. So yes, we can use these things. Yes, we should be aware that there are certain limitations, and we need to learn what are they.
So many lessons learned from what I can hear from you about how the pandemic actually was a game changer in how we adapted to it, but also one of the lessons that we took, I would say, collectively or as a society, was to be better prepared for the future. This is what is coming on and on again. What would you take, or how does that resonate according to you on the, let's say, in the mental health space?
I think that what we learned is, first of all, we can be very flexible if needed. Secondly, I think we can use our resources much better than we thought before. There was always this idea we need more resources in order to do good quality care. As a matter of fact, I think if we use our resources more meaningful, more to the point, I think we can look for much more people more often and more efficiently. So these are the 2 things I would say which resonate. So first of all, more flexibility, more possibilities. Well, the third thing, maybe that's the downside of it, that you shouldn't think that, with the high degree of combination of Zoom meetings, so that an expert, in the past he would have 2 sessions or 3 sessions, then he would walk over to another building, then he would sit in his car and then drive over to the other hospital, and that made him, half an hour rest. Or he had a cup of coffee, then he went to the canteen and so forth. So no drive, no walking off, no coffee, no canteen. So instead of 3 sessions or 4 sessions, you have 8 sessions. That's the other thing is, I think we need to learn to work with these Zoom sessions more cautiously, because otherwise people will burn out, people will get tired, they will get fed up. So as I try to learn with my secretary, so what we do, if I do 1 hour Zoom, how many minutes do I need just to recover? So, is 15 minutes fine? So rather do 45 minutes and 15 minutes and then start to the hour. And, how many meetings can I do with being active, and and how much time do I need to prepare that and to do the work afterwards. So that's another thing people don't take into account. And along with that, this home office thing is, in the beginning we thought, oh, this is wonderful, and then we do this all from home, and this is all better, and so no. I don't think so. Because you see, if you're sitting in your kitchen, surrounding by two kids with unwashed plates, and yourself, you're not having the time even to get brushed and things like that, I don't think it's a good idea. So I would say yes. Again, it's like in the therapy. I think you need to have a certain form and a certain format of that. That means, even if people do home office, that needs to have some points. One of these points is, has the person which I send into home office, do they have a room at home? A little room they can go to. What about the technical equipment? Do they have a computer? What is the quality of that? Yeah. And the third is, I find very important, what is their social structure? Do they have a little phone call in the morning? Do they have a coffee together? What about a Zoom lunchtime? What about afternoon or Friday afternoon when you went to the pub? I mean, can't you have a sort of Zoom beer? I think these are important issues, because people are not only that they get lonely, but they get fed up with the Zoom. And so, that's the other part where I would say, yes, it's a big advantage, but we need to learn how to handle this. So what is good? What is the amount? What is the form to actually present these virtual meetings to the specialist?
So do you think that this is another type of guidelines that EPA could come up with, after after the virtual psychiatry is the use for and the relevance for population, self-discipline, and no, but as you mentioned more seriously, we are back to the initial statement you were making on increased stress levels that this is all generating. Peter, just a reflection on work being done by WHO at the moment that they call building back to better. In the kind of post-COVID era, if ever we are going to achieve that. What do you think, in your view, would be the number one priority in mental health in this idea or this philosophy of building back better?
Well, for me, number one would be to really stop maybe and think about what is really needed for a person. So let's give an example. Something I will work on in my mandate is a core guideline to treat patients with schizophrenia. Because if you look around in the world, you will find 20 plus guidelines. Basically, they are similar, but on the other hand, they are different. So my dream, if I may say, would be that, we have an EPA core guideline. Well, let's say the 10, 15 most important suggestions are written down, treatment, acute treatment, long-term treatment, things like that. We will transfer that into a living guideline, because that's another issue. That means that every 3 months, the current literature is included. So people read this and say, okay, there's a little passage, we need to add this. And this living core guideline is then used in the 40 NPAs, and so everyone can adapt it. Let's say treating schizophrenia in Bulgaria is different because there are certain drugs available and others not. Or psychotherapy is only available for 30 minutes and not for 50 minutes. So, but we agree as EU or EPA on a core of treatment. So coming back to your question would be, yes, building it back better. I would say this is the chance to think about really, what is needed, not in the sense of maximum, but reduce it and say, what is really needed to treat someone with depression, with addiction, with schizophrenia efficiently. So what is minimum? And then next question would be, what to give to whom, how long? Because I think we should go away from the idea everyone gets everything. So we should more define what is needed and then say, does everyone need that? Or are there certain groups of patients who have a better outcome? They need less. But others, if we then, look at their course, they would, maximum treatment from the beginning. So yes, building it back. I think we have good care. It's not the question that we're building on a bad basis. But I think we are a bit, I don't know whether that's the proper word, disorganized. We are not organized well enough with what we have, diagnostically and especially therapeutically. So building it back, but not in the way it was, but building it back more orderly, clearly, so that the patient, the relatives, and the professionals should know better when to do what for how long.
All right. I think, Peter, this is bringing us to the end of this podcast. But before concluding, I'd like to leave you maybe the opportunity for a last word, if you like.
Sure. Yeah, first of all, once more, thank you very much. And as you can see, I'm very much a fan of actually using telemedicine. I mean, that was part of our topic, so COVID and telemedicine, using telemedicine as a chance actually to improve the care for people with mental health. And I do believe that EPA can lead here an important role, because we have more than 40 countries, more than 80,000 psychiatrists, and I feel that it is now the chance to actually use what have we learned, what did we think was good, and that we keep this momentum in order to reform what we have done for many years in order to look after people and to care for people with mental illness.
Thank you very much, Peter, for these concluding words and this positive note. I mean, as far as I'm concerned, I very much enjoyed our discussion and this passionate focus on mental health, and particularly in the context that we discussed. It was a pleasure to host you today. Thank you also to our listeners, and stay tuned for more Brain Talks in the near future. And for all the latest Brain Innovation Days news, don't forget to follow us on our social media channels. Goodbye.